This conference will now be recorded.
Good morning, Pawan.
Good morning, sir.
Am I audible to you all?
Yes, sir.
Yeah.
Yes.
In this class and the coming classes, I will be discussing about the various diabetes and their presenting problems. I'm talking about the diabetes. Usually, most of the diabetes, how the diabetes occurs, how or what will be the preventive measures you have to be taken for non-diabetes to postpone the occurrence of diabetes, and what are the precautions to be taken in patients diagnosed with diabetes. What are the food habits to be taken there, what will be the presenting complaints, and what will be the treatment options that will be available for the treatment of diabetes, and all these things will be taken in your coming classes. And this is mostly the diabetes and the endocrinology. In endocrinology also, diabetes will be covered only to a few parts, but in detail will be discussion in our class. So coming to first, initially we're coming about the glucose metabolism. What is the principal source of glucose? What is the principal source of glucose? So glucose is mainly present. Glucose is mainly comes into the blood by the food we take, and the glucose hemostasis is usually controlled by multiple organs, but mainly by main role is being played by the liver. So, and also it is also supplemented by the intestinal absorption of glucose after the meals, and uptake of glucose by peripheral tissues. So this glucose that is produced by the liver and that is supplemented by the food we take is has to be uptaken by the peripheral tissues such as the skeletal muscles and brain for their proper functioning, because as you all know that for the brain the principal source of food intake is the glucose, and there is no specific production of glucose within the brain, and in the absence of glucose, sometimes the brain cells takes the ketones as a principal material for food for their functioning. And for the skeletal muscle, it is primarily depends on the glucose for their proper functioning. So after ingestion of the meal containing that is carbohydrate, the blood glucose levels are maintained by suppression of hepatic glucose production. So when you take a food that is containing a carbohydrate content, so it sends the signals to the hepatic glucogenolysis. Glucogenolysis will be stopped, and there will be stimulation of hepatic glucose uptake. So there will be hepatic glucose uptake will be increased, and glucose uptake by peripheral tissues will be stimulated. So this is by GLUT4 inhibitors. Next, then the insulin, because the insulin plays a vital role in the regulation of glucose metabolism and storage. And there are many factors that are released from the gut that augment the insulin release, including amino acids and hormones such as the glucagon-like peptide, GLP-1, and gastrointestinal peptide. These also play a role in the regulation of the glucose in the body, but primary regulator will be being the insulin. So what will be the metabolic actions of the insulin? So this what will the insulin do? It increases the carbohydrate metabolism, and it increase the glucose transport within the muscle and adipose tissue by GLUT4 transporter system, and it causes glucose phosphorylation. It also increases the glycogen synthesis. It increases the glycolysis, and it increases the pyruvate dehydrogenase activity and pentose phosphate shunt, and it decreases the gluconeogenesis and glucogenolysis. It decreases the glucogenolysis and glucogenolysis and gluconeogenesis. And when coming to the lipid metabolism, it increases the triglyceride synthesis, fatty acid synthesis, and lipoprotein lipase activity. Whereas it decreases the lipolysis, ketogenesis, fatty acid oxidation in the liver, and lipoprotein lipase synthesis in the muscle. And when coming to the protein metabolism, it increases the amino acid transport and protein synthesis, whereas it decreases the degradation of the proteins. So this insulin release is greater when glucose is administered parenterally, that is through mouth. And this is when, apart from when when the same amount of glucose is given through oral route and IV route, the amount of insulin that is released will be more when given in the oral route. This is because this phenomenon is known as incretin effect. And this post lunch, that is postprandial, glucose rises in the portal vein, and there will be fall in portal glucagon concentration. You all know that there is always a reciprocal relationship between the glucose and the glucagon concentrations. When one increases, the other one falls. So when this glucagon concentration falls, there will be suppresses. This suppresses the hepatic glucose production and results in net hepatic glucose uptake. So next coming to, and depending on the size of carbohydrate load, about only 1/3 of initial glucose is taken up in the liver. So that is the more than 30% of the food, more than 33% of the food that carbohydrate content is taken up by the liver. And this insulin, and in the presence of insulin, it promotes the, as already discussed in the previous slide, this insulin promotes the glucose uptake in the skeletal muscle and adipose tissue through glucose transporter, that is GLUT4, that is GLUT4, glucose transporter 4. And the intestinal glucose absorption declines between meals, and portal vein insulin and glucose concentration fall while glucagon levels rise. That is this occurs in between the meals. Then coming to etiology and pathogenesis of diabetes. So in both the common types of diabetes, that is, what are the common types of diabetes you know of? What are the common types of diabetes you come across in your postings and all those things?
Type 2 diabetes.
What are the two types?
Type 1 and type 2 non-insulin dependent and insulin dependent diabetes.
Yeah. So one is type 1 diabetes and one is type 2 diabetes. Other one of lesser onset is MODY, that is maturity onset diabetes mellitus. And this coming to type 1 diabetes, previously it was termed as insulin dependent diabetes mellitus, because in these type 1 patients there will be antibodies against the beta. There will be formation of antibodies against the insulin secreting beta cells of the pancreas. So there will be no insulin production, leading to increased glucose. So you have to supplement insulin from outside. And coming to type 2, it is previously termed as non-insulin dependent diabetes mellitus. So in these patients, there will be resistance to the insulin. There will be insulin production, but the receptors will be resistance to the insulin. So these patients are usually given oral hypoglycemic drugs as a insulin sensitizers like sulfonamides are usually given, that is metformin is usually given for sensitization of this insulin. But as the duration of type 2 diabetes progresses, there will be destruction of these beta cells, and further there will be leading to insulin administration of insulin in patients of type 2 diabetes mellitus also. So this is a misnomer. This classification of insulin dependent diabetes mellitus and non-insulin dependent diabetes mellitus become misnomer. Then coming to the type 1 diabetes, the pathology is, it is usually T cell mediated autoimmune disease. So as previously told, it is a, there will be progressive loss or destruction of beta cell function, and it takes over a prolonged period. And the pathology in a pre-diabetic pancreas is characterized by insulitis, that is inflammation, that is deposit of the substances insulinites is in the pancreas. So there will be antibodies, islet cell antibodies will be present before the clinical presentation of type 1 diabetes mellitus. So before the patient presented to you, there in the blood there will be antibodies that are present because in islet cells of the pancreas, beta cells, that is beta or islet cells of the pancreas. So there will be autoimmune destruction of these cells leading to decreased production of insulin. So there the genetic predisposition of these cells is the HLA haplotypes, that is DR3 or DR4, are usually associated with increased susceptibility of type 1 diabetes in patients of Caucasians. And then what will be the environmental predisposition? These environmental predisposition, they fall into three categories. These fall in viruses, specific drugs, and drugs or chemicals or dietary constituents. So what are the viruses that are implicated in the etiology of, that is in the formation of type 1 diabetes mellitus? These viruses include mumps, Coxsackie virus, that is Coxsackie B4, retroviruses, that is HIV virus, rubella, that is it is most common cause of in utero, and cytomegalovirus and Epstein-Barr viruses. And dietary habits, dietary constituents include various dietary nitrosamines, that are smoked or cooked meats, and coffee have been proposed as potentially diabetogenic toxins. And the metabolic disturbances that are seen in type 1 diabetes are, one is hyperglycemia. So as there is lack of insulin, there will be more of glucose, which leads to glycosuria and dehydration, because when passing glucose with along with glucose, there will be passage of water also, so leading to dehydration. So when there is a loss of fluids from the body, it causes fatigue. Because of this increased glucose and this, there will be polyuria and nocturia, and due to dehydration there will be thirst, and there will be increased, this polydyspsia is increased tendency to eat food. And these, as there is more of glucosuria, these patients are subjected to urinary and genital tract infections. And due to hypotension there will be, and due to dehydration it leads to hypotension and formation of tachycardia. So there will be unrestrained lipolysis and proteolysis occurs, which resulting in weight loss. So again there will be ketosis occurs, that is fatty acid synthesis occurs. So there will be formation of ketone bodies. So and when these ketone bodies or levels are increased in the blood, it leads to ketosis. So what are the, this is the flow chart. This is a flowchart that shows what are the metabolic abnormalities that occurs in the case of insulin deficiencies. So when there is insulin deficiency, there is decreased glucose uptake and utilization leads to hyperglycemia. There will be increased glycogenolysis leading to hyperglycemia, and there will be increased proteinolysis and increased gluconeogenesis, again leading to, these all leads to hyperglycemia. So when there is hyperglycemia, it causes glycosuria, and glycosuria causes osmotic diuresis leading to dehydration. So this dehydration, there will be this dehydration causes because of secondary aldosteronism, hyperaldosteronism, there will be deficiency of potassium, and this dehydration leads to hyperosmolarity. So the renal function will be decreased, and again there will be increased lactate production, so leading to metabolic acidosis. There will be ketogenesis formation and increased free fatty acids and glycerol to liver. So all these are the various metabolic abnormalities that occurs in the liver, that occurs in the body in the cases of insulin deficiencies. So coming to the pathology of type 2 diabetes mellitus. So usually the type 2 diabetes mellitus is diagnosis of exclusion. That is, after excluding all other types of diabetes, that is type 1 diabetes and other causes of diabetes that I will be discussing in the at the last of this seminar, this PPT. Then we will label these patients as type 2 diabetes mellitus. So initially insulin resistance leads to elevated insulin secretion in order to maintain normal glucose levels. So insulin resistance, these patients of type 2 diabetes will be having impaired glucose tolerance, and there will be, as there is insulin resistance, more and more of insulin is secreted by the islet cells of the pancreas. As for secreting more and more, they will work hard and ultimately they will lose their function and they die, leading to insulin deficiency. So patients with type are often associated with disorders such as hypertension, dyslipidemia, non-alcoholic fatty liver disease, and women polycystic ovarian syndrome. And this cluster of symptoms is usually termed as insulin resistance syndrome or metabolic syndrome, that is, or syndrome X. And for all these conditions, the primary cause of for all these conditions, the primary condition is there is insulin resistance. Then what causes insulin resistance is unclear. And one of the theory that tells you that the insulin resistance is usually caused by central obesity, that is deposition of the fat within the central abdomen. So this is one of the major cause. This one theory tells that the cause of insulin resistance is central deposition of adipocytes, and intra-abdominal adipose tissue is metabolically active and releases large quantities of free fatty acids, which may induce insulin resistance. And this is according to this theory. Another thing is decreased physical activity is another determinant of insulin. This physical activity is an important determinant of insulin sensitivity. So immobility also causes insulin resistance, and there will be more and more of fatty acids within the body. So there will be deposition of fat in the liver and is associated with central obesity and exaggerated by insulin resistance or deficiency. So gradually there will be beta cell failure. That is, at the time of diagnosis, around 50% of the beta cells will be lost, and their function declines progressively. Then genetic predisposition, largest effect is seen in this variation in TCF7L2 gene, and these genes mostly contribute to type 2 diabetes, are involved in beta. These apart from contributing to type 2 diabetes, they also cause beta cell dysfunction and regulation of cell cycling and turnover. So there will be arterial regulation of beta cell mass. So what is the risk of developing type 2 diabetes mellitus in siblings and individuals with type 2? So the age at onset of type 2 diabetes in man is 25 to, if one sibling develops diabetes at 25 to 44 years of age, the other sibling can get it. Then 53% of their siblings can get diabetes. Then 53% of their siblings get diabetes. If they develop diabetes at 45 to 54, only 37% of their sibling can get diabetes. And if the patient develop diabetes at 55 to 64 years of age, only 38% of their siblings can get diabetes. If he developed diabetes at the age of 65 to 80 years of age, and only 31% of their siblings can get diabetes. So what are the environmental and other risk factors? I previously diet and obesity. So the more consumption of fast foods that are, and consumption of foods that are rich in carbohydrates and unfractionated fats. Yeah, these increase the tenfold. They increase the risk of getting diabetes tenfold. And the patients who are obese, that is the BMI more than 30, there are tenfold increase in the development of diabetes mellitus, and it is most commonly common in middle-aged individuals. And what are the metabolic disturbances in type 2 diabetes? It is also same as that of type 1 diabetes, and there will be history of fatigue, and there will be osmotic symptoms. And when there is insulin resistance and insulin deficiency, there will be hyperglycemia and leading to glycosuria and dehydration and all those things conditions. So what are the other specific types of diabetes? That is genetic defects of beta cell function, genetic defects of insulin action, that is leprechaunism and lipodystrophies, and pancreatic disease. That is in case of pancreatitis, pancreatectomy, that is in case of neoplastic disease or the carcinoma of the pancreas, cystic fibrosis, hemochromatosis, fibrocalculus pancreatopathy. In all these conditions, there will be loss of pancreatic tissue, leading to decreased in deficiency, decreased insulin secretion, leading to diabetes. And there will be excess endogenous production of hormonal antagonists to insulin. It is growth hormone, which is also insulin-like hormone, so leading to acromegaly in case of excess use of in excess production of glucocorticoids, leading to Cushing syndrome, and in glucagonoma, that is increased glucagon production, and catecholamines, pheochromocytoma, and thyroid hormones, thyrotoxicosis. All these conditions, if there is any excessive production, that is excessive endogenous production of growth hormone, glucocorticoids, glucagon, catecholamines, and thyroid hormones, it also causes decreased insulin production. And there is drug induced, that is in most conditions like corticosteroids, thiazide diuretics, and phenytoin, these all cause diabetes. And uncommon forms of immune mediated diabetes such as IPEX syndrome, that is immunodysregulation, polyendocrinopathy X syndrome, and some of the associated genetic syndromes such as Down syndrome, Klinefelter syndrome, Didmont syndrome, Turner syndrome, Wolfram's, and the diabetes insipidus. All these conditions will cause diabetes. And other is gestational diabetes, that is the detection of diabetes after 20 weeks of following 20 weeks of gestation in pregnant men. This is a primary introduction to diabetes, and in the next class we will be discussing about what are the presenting problems in case of diabetes and all those things. Up to now, any doubts are there? Next, coming to what are the investigations you do in diabetes? Any doubts up to here?
No, sir.
Yes. Yes or no?
No, sir.
No, sir. Hypoglycemic. Next, coming to the investigations. What are the investigations you do for a patient to suspect he is diabetic? One is blood investigation and the other is urine investigations. What in blood investigation, what you will see for in blood investigations, you see for levels of glucose. You will see any ketone levels that are present. And in while coming to the urine investigations, that is urine testing, you will see the presence of any presence of sugars in the urine, any proteins that are in case of proteins that present in the urine, you will suspect any urinary tract infections. Second thing is any ketone bodies, ketosis, ketonuria. So these are the investigations we will do for a case of diabetes. So if there are any doubts, I will close the class now. Any doubts?
No, sir.
No. Okay. Then we will be discussing the further topics in the next class. Thank you.